which is not always an easy thing to do. For those of you who haven't really had the time to enjoy this drawing, I will put it back during the Q&R session. So let's start with our webinar. Let me just see how I'm gonna get it. Yes, well, I'll be talking about selective laser trabeculoplasty. Now, you could, we have no conflict of interest to declare, you could always wonder why. Why the hell do we need another therapy for glaucoma? Is it that important? Don't we already have more than enough therapies? Well, I'll tell you why. Glaucoma, we know, is the chronic disease of the optic nerve. In most cases, the etiology is an intraocular pressure which is too high, meaning above 21 millimeters of mercury, pushing on the retinal nerve fiber layers and hurting them, and in the end making them die. We all know, though, there's an entity where IOP never rises above 21 millimeters of mercury. We call that low or normal tension glaucoma. And the phenotype of that kind of patient are the thin young women. Now, all in all, what do we know about glaucoma in general? Glaucoma is a very distressing disease in that it has no symptoms at all. It acts, as we say, a little bit like a thief in the night, because you hardly feel anything, and by the time that you feel anything, it's far too late to recover. Prevalence is about 2 or 3% of any population. It increases with age, and women are hurt more easily than men. With all that, we could ask, is this perhaps mostly a Western problem, seeing that it's mostly connected to age? Well, no, it isn't. Glaucoma is worldwide the leading cause of irreversible blindness. We all know that cataract is the leading cause of reversible blindness in the world. So it's really a worldwide problem. Here's a map on the prevalence of glaucoma. We see Europe, Northern America here in these kinds of prevalences. But when we're looking at the higher rates, we see a lot of pink and a lot of yellows here in Africa and in South America. So no, glaucoma is definitely not a Western problem. It's also a problem of the world's, the parts of the world that seem to be underdeveloped. So it's really a worldwide problem. Aging of the population and growth of the population will make the problem of glaucoma and glaucoma therapy even bigger. So it's supposed to be one of the biggest ocular diseases of the coming centuries, and definitely worth our attention. Although we know vascularization has a certain role in glaucoma, lowering the IOP still remains the main standard of treatment. In the early manifest glaucoma trial, it was proven that every millimeter of mercury an IOP gets lowers about 10% the risk of disease progression and disease onset. So it's worth lowering the IOP as much as possible. Up to now, our decision tree was as this. We first start with medication. If that didn't really work out, we would try some kind of laser. And if everything else failed, we would do surgery. So here's a question for you, and the first poll we have. Do you personally use SLT?
So I started.
So you can answer one. Yes?
Yeah.
This is the second.
No, sorry. Sorry.
Oh.
I started, sorry. Here we go. Area.
Okay, so you can answer yes or no, or I would, but I don't have any access to an SLT.
Wait, I have it. Start. Yeah.
Okay. So just, we see results coming in. We'll just give you about 20 30 seconds to get your votes in.
Yeah. Still more. Okay, I think we can stop.
All right, so here we are.
And here are the results.
Okay, thank you very much. So 75% of you are using SLT. That's very nice. That's a very good percentage. That gives us some clue as to whether you will know what I'm talking about. We'll immediately go to the second poll, I think.
Yeah.
Question is, how do you use SLT? You can either use it as a primary therapy, let's say as an adjunct therapy, that's answer number 1. You can use it as a replacement therapy, which is number 2, or as a primary therapy. I would say several answers can be right.
Yeah,
I suppose the computer can take care of that?
Yeah.
Okay, and we already see the results coming in.
Mm-hmm.
We'll give you a few more seconds.
Yeah, 5 more seconds to vote. Okay, here we are.
Okay, so a lot of you are still using it as an adjunctive therapy, not so much as a replacement, but already 50% as a primary therapy. That's a good start. That's not such a bad number. That's okay. Good. Okay, so we know where you are now, and we'll just continue just on how we get on with glaucoma. Up to now, main therapy would be medication. We have 5 different classes of families, 5 different families that can be used as kinds of medication to treat glaucoma. And we are very persistent with it. We tend to use 1 drop, 2 drops, 3 drops, 4 or 5 drops, anything to get those drops and to get the pressure lowering. We're very persistent with it. If this didn't work, we'd use laser trabeculoplasty. In the early days, we will only have argon. Lately, we also have selective laser. Iridotomy is something used for close or narrow angle glaucoma. Cycloablation is something we really try to avoid. So mainly the main therapies of laser would be trabeculoplasty. Trabeculectomy used to be the golden standard, but lately we also have mixed. We have minimally invasive glaucoma surgery, and there's also the non-penetrating surgery. So maybe our whole tree of decision is due to change a little bit. We're going back to medication. Main problem with medication is that it has a whole lot of local side effects. We all know that preservatives like benzalkonium chloride here is renowned for having very bad effects on the anterior surface of the eye. So here's the third poll. How conscious are you about preservatives? Do you use preservative-free drops? 1, always. 2, regularly. 3, sometimes. Or 4, you never do.
Yeah.
And we have the poll running again. We'll give it some time.
Then 10 more seconds to finish. Okay, here we are. The results.
Okay, here are the results. I thank you very much for being so honest, because we all know we should be using preservative-free drops all of the time, but I don't do it either. I use it when I think of it, but most of the time I'm using preservatives and I'm not really very conscious about it. Perhaps in my case it's because I use a lot of SLT, but we're more or less used to prescribing a certain drop and we continue using it. Well, actually we shouldn't, but it's very honest of you to be honest that you don't, and that you sometimes use it. So we know local side effects are caused very often by preservatives. Problem is not only by the preservatives. Medication doesn't only create local side effects, it also creates systemic side effects. The problem of those systemic side effects get even bigger because our colleagues, the general practitioners, are hardly aware of the fact that patients are using eye drops and don't really expect any side effects of them, which is something to think about. And of course, in any chronic disease, there's also a problem of compliance or adherence. Let me go into that. This is a list about all of the local side effects. And you see all of the families of anti-glaucoma drops here. Now, there are some side effects, like the changes of the lashes, we are not very angry about. Everybody wants very dark, long eyelashes, so we're very happy about the fact that some of the drops create that effect. But there are a lot of other problems, like the allergic blepharoconjunctivitis, a burning irritation, a conjunctival hyperemia. These are very unwanted, very disagreeable side effects. Since we're working with an elderly population, you very often get older people who are already on artificial tears. And I have a real problem on giving anti-glaucoma medication that will enhance problems to people who already have ocular surface disease. I think we should avoid that. Beta blockers are known to have the most systemic side effects. We know beta blockers change the heart rhythm a little. They enhance asthma. They work on the nervous system and on male potency. Beta blockers are renowned for that. Unfortunately, when we're looking at the list of all of the drops, almost all of them have some kind of the same side effects. They almost all work on the heart. Some of them enhance asthma, and impotency can happen with more than just beta blockers. Any chronic disease has problems with compliance and adherence. And the problem is even bigger in glaucoma because you don't feel anything. On the contrary, you have a disease that gives you no problems whatsoever. And when you're putting in the drops, they give some irritation. So you're more bothered by the therapy than by the disease in itself. This is not very convenient to have a high compliance. So tests have been made, and we know that if you prescribe one eye drop, adherence is about 70%. 30% of your patients will not be taking the drops you prescribe. Once you're using 2 drops, adherence drops to about 50%. And once you're using 3 kinds of drops, adherence goes back down to about 30%. So don't even bother prescribing more than 2 bottles because people will simply not be taking them. This is also a reason why combinations preparations have been developed to lower the number of drops, the number of bottles a patient will have. Now, we are working with an elderly population, and they have all kinds of problems like shaking hands. So getting those drops into the eyes is really a problem for them. And very often they are dependent upon people, upon other people to get the drops in. So here's another question for you. How confident are you that people are actually taking the drops that you prescribe? One would be, I'm very confident. My patients are very good patients and they always take everything I prescribe. 2 is reasonably confident. 3 is I'm confident, but not altogether. 4 is I'm not very confident. And 5 is I'm not confident at all. We'll
Now you can vote. Yeah. Ten more seconds. Okay, here we go.
Okay, so the majority is reasonably confident, not all that confident, and that's a good thing. It's very hard to get a real clear view on whether patients are taking your drops or not. It's very difficult. And it's good to be conscious of it. Now, I'm going to put away the poll and get to the next video. Sorry, I'm trying to get the poll out of my site. Not getting it out. Go away. Go away. I'm sorry, I still have that poll in the middle of my image. And
I just stopped to show the results.
yes, but I can't get rid of it. Here we are. Well, sorry. This is an image I made to demonstrate why I started working with SLT. I've been working in private clinics for about, what is it, 25 years now, but for 4 years I've been working in a public hospital, and I was confronted with rather bad patients. People would come in once every year, once every 2 years, they would use their drops or they would not use their drops. I was really very afraid about what they are doing or were not doing, and I was very unhappy about it. And of course, we all know that a drop that isn't taken cannot possibly work. So I was definitely looking for some kind of solution, some kind of treatment to do just once and get it over with, and be sure that if they were coming back after a year or even after 2 years, they would still have some kind of treatment. So I started working with laser trabeculoplasty. At the beginning, it was only argon, and it worked just fine. And after that, I was able to get my hands on a selective laser, and that was even better. And the meaning of this was to get some treatment in for those bad patients that I was completely confident about that they were not taking my therapy. Now, laser trabeculoplasty, be it argon or selective laser, is a very easy outpatient kind of treatment. You put in an anesthetic, you put a little gel on your lens, place the lens on your cornea, and you use the mirror to have the laser beam aimed at the anterior angle, and you're aiming at the pigmented part of the trabeculum. When you're doing argon laser, you have to take care very much to put the spots in the right place. But when you're using SLT, the spot is much bigger and it's much easier to get it. You always have it right. You only have to be sure that you have an angle that you actually see. If you can't see the angle, it's very hard to get any therapy done. When we further compare argon, you see, argon has quite a long time of pulse, a lot of energy on a very, very small area. And what we do is you put a little burning point on the trabeculum. It shrinks the tissue and it tears open, it opens up the adjacent tissue. That's what you want to have. On the other hand, compared to the SLT, you have the duration of the pulse of 3 nanoseconds. So it's extremely short, very little energy, a very big area. So this gives you very little energy on a very big area. So it's a completely different kind of treatment. If you compare the histological changes, this is the kind of crater you create when using argon. You really get some scars there. There are very big, obvious histological scars. In SLT, you hardly see any changes. There are some histological changes, but very, very little. Now, they are both supposed to have a biochemical response, but it's supposed to be much bigger in SLT. The fact that you create scars in the argon makes it a non-repeatable procedure. You can't scarify all of the trabeculum because no outflow will be left. On the other hand, since there's no scar formation after the SLT, it makes it a repeatable treatment. So how is SLT supposed to work? SLT creates a kind of inflammatory reaction. Cytokines, inflammatory mediators, are secreted. They will activate the trabecular tissue. Trabeculum, the tissue will start activating, it will start reproliferating, and it will start working harder. So it makes new tissue, and the existing tissue starts to work harder. And on the other hand, there's an attraction of the white blood cells here. And those white blood cells will start to clean up all the debris at the level of the trabeculum. So there's several kinds of mechanisms here. Both of these mechanisms will increase aqueous outflow, and that will lower the IOP. Now, to me, this is kind of Star Trek. I hope you all know Star Trek. It's a science fiction series in the future. You know, Star Trek, you have Dr. McCoy, who is the doctor of a big starship, and he has some kind of small apparatus, and he goes over the body, and then you're healed. Well, to me, this is kind of the same effect. You don't put in any toxic kind of product into the body. You just give some energy to that body and tell it how to heal itself. This, to me, is the therapy of the future. You don't use any toxic product. The body will heal itself given the right amount of energy, the right amount of information. Now, SLT has the enormous advantage of not being dependent upon just about anything. It's not influenced by whether you're a man or a woman or something in between, whether you're young or old, white, black, yellow, red. It doesn't make any kind of difference whether you've been using drops or not, whether you've already had some kind of laser treatment or not. It makes no difference. Whether your glaucoma is very severe or not, or which kind of glaucoma you have, SLT works on just about any kind of glaucoma. A lot of people with glaucoma have hypertension, makes no difference. A lot of people who have diabetes also have glaucoma, makes no difference. The only definite effect, SLT is definitely influenced by the IOP before laser. If you have a high pre-SLT IOP, you have a higher effect. That's the only really known factor to influence the effect of an SLT. Now, SLT was launched by the group of Mark Latina in 1998. Since then, a lot of the questions have been answered. One of the first questions that have been answered was the question whether selective laser, which only aims at the pigmented cells, is as effective as an argon laser, and it was proven to be just as effective. In the beginning, the selective laser was mainly used as an adjunctive therapy. When everything else failed, you could try some selective laser. But by and by, more and more studies have been made, big reviews have appeared, and by 2010, it was very clear that SLT is efficient. It works just as well as medication, exactly as well as argon laser. It's reliable, it works very good and for a long time, and it's probably a whole lot cheaper than using medication for years on end. Most recently, in 2019, the LIGHT study appeared in The Lancet, which was a very big study examining the effect of SLT as a primary therapy, and their conclusion was that SLT is just as effective as medication, but it's cheaper and it has much less side effects. So we probably have to think again about our whole decision tree and put SLT in the first place. Use it as a primary therapy. Why can we say this? This is a table I've got from a very big systematic review of 2015. Well, SLT has very little side effects. I always tell my patient the worst thing that can happen is that it doesn't work. What we do see quite often is a transient IOP rise, but when we're using the correct kind of drops before using laser, this kind of side effect lowers immediately enormously. There's always some part of pain, there's always kind of discomfort, and there's always very, very often some kind of redness. And I tell my patient that this is exactly what we want. We want to create some inflammation in the eye because it's the inflammation that will make the eye react and will heal itself. So you want some kind of inflammation, and it will last 3 to 5 days. And if people know this in advance, there's no real problem. Now, before SLT, we tend to use some pilocarpine, 1 drop, about a quarter of an hour before applying the laser. That will nicely give you a meiosis and pull the iris out of the anterior angle. We use some apaclonidine to minimize that fast IOP peak, and we use some anesthetic to put in the contact lens with enough comfort. Now here's a question for you. No, let me get this first. There have been a lot of examinations to see just how big a part of the trabeculum you need to treat. 90 degrees has been used, 180 degrees or 360 degrees. Consensus is that the best effect can be reached with about 100 points, not overlapping, over 360 degrees. Now what you want to look for is to have some very small bubbles. You want to have some champagne bubbles, and we more or less say every 5 spots that you put, every 5 laser points, you want to see one one group of champagne bubbles escaping. We know that if you can't get really 360 degrees, 180 degrees works too. And even 90 degrees works. So if you have a patient with an angle which is not entirely visible and there's not so much reaction and you don't see so many champagne bubbles, it's not a real big deal, because even if only a quarter of the points you are getting in really gives some kind of reaction, you still have an SLT that is perfectly effective. So here's a question I wanted to ask. What do you do after the SLT? Do you use some anti-inflammatory drops? Always. That would be answer 1. When needed, so if you see perhaps that your patient has really red eyes, you push answer number 2. Or 3, no, you don't use any anti-inflammatory drops. Here's another.
There we are. Yeah. Then you can vote. Please don't hesitate to ask your question during the lecture if you have. Just use the Q&A tab on Zoom. So we will answer you. I think it's okay, 30 seconds. Here are the results.
Okay, so a majority still actually uses anti-inflammatory drops. Okay. Well, we actually did a study on that. We tried to, in a prospective kind of way, we compared steroids after the SLT with non-steroidal anti-inflammatory drops with no drops at all. And we actually found that it made no difference, not in the effectiveness of the SLT, not in redness, not in irritation. In no way it made any difference. So actually, we're not using any anti-inflammatory drops anymore, but you do tell the patient that you will feel some kind of irritation for a few days. That's important, because if not, they will call you and ask you, I'm still feeling my eye just a little bit, and you will have to say, well, that's perfectly normal. So I'd say stop using the drops after the SLT. Anyway, if you're using them, there's no harm done because it has no negative effect either. So just do whatever you're comfortable with.
Sorry, Myrjam, I have already one question from Dr. Pradutone.
Okay.
Do you stop anti-glaucoma drops before SLT?
No, I don't. What you're waiting for is the body to react. This means you have to wait for at least 4 to 6 weeks until your SLT has any effect. So I tend to see my patients back after about 3 months, and I just tell them to keep on using their drops until the checkup of 3 months. So sometimes I do my first laser first week, second laser I do a week after that. If I see that pressure is already going down, then I tend to stop the drops in the first eye when I do the second eye. But most of the time, I just tell patients to continue using the drops until the checkup of about 3 months. And that's general practice. You just keep them on the drops until you're sure that the SLT will work.
And we have also another question, but I guess maybe you will talk about that later. From Sunil GT, which lens is the best to use for SLT? And what magnification you use to focus the laser beam?
Oh God, I really wouldn't know. I have a Volok lens, but I really wouldn't know which kind.
Maybe the Latina lens, which is almost, you have no magnification on this one, the SLT Latina lens.
I actually want to have a clear view, so I enlarge it rather much. I try to have about the same effect that you would have when doing gonioscopy, because in the end, it's just like doing gonioscopy. You want to have a clear view of your anterior chamber, so I enhance it until I have a really clear view. Even though the spot of an SLT is very big and will hit almost all of the anterior angle, I do try to aim at the pigmented part of the trabeculum.
And another one question from Tatiana Rushko. What do you think about SLT and ALT combination?
I wouldn't see the advantage. ALT will create scars, so it's not repeatable. So why create scars in the trabeculum when you have a therapy which will have the same effect, exactly the same effect, but will not cause any harm to your trabeculum? Because SLT and ALT work exactly the same, with that difference that SLT will do no harm. So I don't think that's a hard choice to make, not for me anyway. I don't even think we have an argon anymore, actually. Yeah, we do, because we use it for the retina.
Okay, we have more questions, but we'll talk about that later, so we can move on the lecture.
Okay, I'll just get the poll out of my site again. Go away. Yes, all right, and we'll go back. What we do have with both ALT and SLT is a weeding of the effect. The effect of both ALT and SLT diminishes. It gets less in time, with that difference that SLT is repeatable. A lot of studies have been done. I just mentioned this one by Francis, saying that SLT is perfectly repeatable. It can be repeated as soon as already 6 months after the first SLT, and the effect of a second SLT will be exactly the same as the primary SLT. So that's great. Anyway, to me, I always like to tell patients in advance just what they can expect. So I was wondering how many people actually have a good effect of an SLT and how long will it last. So that's the reason why we started another study after the one on anti-inflammatory drugs and replacement of the SLT. And we started a prospective clinical trial aiming to examine the time needed to redo an SLT. We included just about any open-angle glaucoma or ocular hypertension that needed an SLT treatment. We used SLT as a primary treatment on patients who were treatment naive. We considered replacement SLT on people already on medication and with a controlled IOP, but with some kind of hindrance about it. And we would consider adjunctive SLT, patients who were on medication, but who had an IOP that was not controlled at all. We would apply SLT over 360 degrees, an energy starting at 0.9 millijoules and enhanced until we would see champagne bubbles every 5 laser points we put, and we would apply 100 points over 360 degrees, non-overlapping. IOP would be measured after 1 week as we were doing the second eye, then after 3 and 6 months, and then every 6 months at least. We have a follow-up of about 4.5 years. The definition of success would be achieving a preset target pressure without any medication in the case of primary SLT, with less medication than before, trying to replace the SLT, and with the same kind of medication, but now with a nice target pressure when we were applying adjunctive SLT. What we define as a non-responder is a target pressure which was not achieved at 3 months and again not at 6 months. People that do not have a good target pressure at 3 months and at 6 months, we tell them, you really don't react to SLT. You are one of the rare people who do not respond well. Here's our demography. We have an elderly population, which is a classic glaucoma population, a little bit more women than men, mainly Caucasian because we are here in Antwerp, Belgium. 36% of our SLTs were primary. I do a lot of replacement SLT because I really don't see the reason why we should continue using medication that can have side effects, that can be forgotten, that gives all kinds of problems. So I replace any kind of medication that comes by, and 17% of our SLTs were adjunctive. The mean energy we use is 1.4, and we're always putting just about 100 points of laser. These are our results. Well, it was not really a surprise that the highest pre-laser IOP would be in the adjunctive SLT group, followed by the primary SLT group, and then the replacement SLT group, because this one would be the group with already controlled IOP. We have much more normal tension glaucoma in the group of primary SLT, because that's a little harder to diagnose. Not really a significant difference, a little bit better visual acuity in the primary SLT group. There was some, excuse me, I'll have to go back, I was too fast, a little bit thicker cornea in the primary SLT group. No significant difference in the cup disc ratio, nor really not a significant difference in visual field, mean deficit, or in focal loss of volume on the OCT. Difference was really not significant. definitely a significant difference between the groups concerning use of medication, because people on primary SLT would not be using any medication, and prostaglandins are the vast majority of the drops people are taking. This is our flow chart. We had 237 eyes to start with. The moment we did this analysis, we had 260 eyes which have had a follow-up of more than 6 months. Among these, we had 22 eyes that were considered non-responders, who did not have a good target pressure at 3 and 6 months, and 194 eyes were completely successful. So this is a very important number to tell your patients. I tell my patients, worst thing that happens is it doesn't work, and it doesn't work in about 10% of the people. In 90% of patients, you have perfectly successful SLT. 10% of people do not react to the SLT, and it's not worth trying a second one or a third one. They just don't react. And I'm always surprised by the very strange and low figures I see published in all kinds of articles, because in my case, most people react just fine to the SLT. When we're looking at the evolution of the mean IOP, you see the IOP is a little bit higher in the group of adjunct SLT because they were uncontrolled. Then second, a little bit higher in the primary SLT, and the replacement SLT, since they already had a controlled IOP, is the lowest. And you get a mean in the middle. You see they can start at a little bit difference. By 3 months, that difference gets much smaller, and by 6 months, the difference has disappeared, and it stays actually just about the same in the rest of the follow-up. So this is the kind of curve you would expect after an SLT. It starts, we didn't have so high an IOP to start with. It goes immediately down at the first checkup of 3 months. At that time, we would stop some kind of drops. We always try to stop 1 drop. If they're using 2, we stop 1. That can lead to a little bit of a rise by the second control at 6 months, and after that it stays relatively stable. But you see quite a big change in the mean number of medication people would be using. We started at a mean of 1 drop per patient, meaning there were a lot of patients not using any drops. There were patients using 2 drops. By 3 months, when we have seen them already after 1 week and we've stopped 1 drop, the number of medication goes down. It continues to go down because every time we see them and the IOP is okay, we try lowering the medication and it goes down to very, very little. We have a mean follow-up of 22 months, and of the eyes that were successful in the beginning, we had to redo 12% of those eyes, and 88% remained perfectly successful, which is a very good success rate. When we compared the first SLT with a rapid diminishing of the IOP to the redo SLT, you get exactly the same kind of reaction. SLT, the IOP goes down by 3 months, and then its rate stays relatively stable. We have a difference in mean number of medication between the first SLT, in which it goes down very rapidly, compared to the redo SLT, because we chose not really to start up any medication. The variation you see here is just due to the patients that remained in the study for long enough. So we chose not to restart on medication, but to redo the SLT. Now, how soon do you think retreatment may be needed? And here's another poll. So if you think a retreatment may be needed after 1 year, you press 1. After 2 years, you press 2. After 3 years, you press 3. And after 4 years, you press 4.
Okay, so let's start. Here we go. Myrjam, just one confirmation for Mufawak Zainar. He asked, do you mean 100 laser shots for 360 degrees in one session?
Yes, yes,
Okay.
I do. It hurts just a little bit, and it takes a little bit of time. So you have to tell your patient that they will feel it. It doesn't really hurt, but you feel it like tiny needles, let's say. It's not really comfortable. It's not extremely painful, but it's good to tell your patient that they will feel it.
Okay, so let's see the results for this question. Yeah.
Okay, so most people do seem to think you already need to redo an SLT after 1 year. I suppose this is because a lot of publications indeed tell you that after 1 year, hardly any SLT seems to work. I'm always surprised about that, because in my case, most of my patients were just fine. I'm happy to see there are also some people who think SLT is okay up until 2 years or 3 years, and we'll see just what our results were. And I'll try to get rid of the, here you go, okay. And go to the next. You see here the survival, the Kaplan-Meier survival curve that we had. And these are the months here, months after the first SLT. You see almost every SLT is successful the first year, a little bit less the second year, but then after 2 years and a half, which is 30 months, you get a steep slope or ups, it goes down immediately, and then it starts going down very rapidly. And when we put that in numbers, the success rate stays in the high 90s at 1 year, at 1.5 years, at 2 years, it's still around 90%. 2 years and a half even, but there's a big difference between 2.5 years and 3 years. Then it suddenly gets down. And after 3 years and a half, you have a success rate of 66%, and after 4.5 years, you have about 55%. So it changes, and the main change is here. If we put that in another curve, the hazard curve, so the risk of having to redo an SLT, you see you hardly have any redos the first year, the second year hardly any. After 2 years and a half, whoops, it goes up, and then the rate of having to do a redo gets higher. We put that into numbers. You see a redo rate after 1 year, hardly any. No redo after 1.5 years, hardly any after 2 years, still very little after 2.5 years. But there's a big jump after 2.5, between 2.5 and 3 years. After 3 years, you already have a 30% of patients have to have a redo, and after 4.5 years, it's 45% of people who need a redo, who need a second SLT. So here are our conclusions. SLT is a very effective way to lower IOP. You have about 10% of people who do not respond. I don't bother to retreat them. If they do not react to first SLT, if they have a bad target pressure, they don't reach their target pressure at 3 months and 6 months, I don't bother doing a second SLT, which means 90% of our patients worked perfectly. They react just fine. The mean redo seems to be most common at about 31 months. So after 2 years and a half, redo is most common, which is still not so very much, because the need to redo was actually 8% after 2.5 years, but it goes up to 20% after 3 years, 33% after 3.5 years, and 45% after 4.5 years, which means that after 4.5 years, 55% of your SLTs are still extremely happy, don't need a redo, and are still very successful. And I'm happy to present these results because it's a bit of a contradiction with most of the numbers that have been published, so I will be short to publish these very shortly, because you see, SLT does work. It works for quite some time, and if it doesn't work again, just redo it. I think that'll be just about the end of our meeting. I'm sharing with you our very nice images of our clinic at Medipolis. And if you allow me, I'll just put back on the images at the beginning with the drawing of Myrjam Waite, because that's a very nice kind of image to have in background.
Thank you very much, Myrjam, for this very interesting lecture and all the results. And we received several questions. So some of them is from Ahmed Mirshai. Is it safe in patients with uveitis? Have you seen severe uveitis with a very high IOP spike after SLT in PDS?
Okay, I'm just gonna, here we are, okay. I'm gonna leave this on. I wouldn't do it in uveitis. People who have uveitis, I don't think you want to have an additional inflammation. So I wouldn't do it, no. Actually, it's the only thing I wouldn't do, but I must admit that in my private practice, I don't see uveitis all that often. Mm-hmm. But what you try to do is to create some inflammation. The same reason you would not apply any prostaglandins or prostaglandin analogs in people with uveitis. They also create some kind of inflammatory reaction. So I would not use it in uveitis. We did the study on anti-inflammatory drops, and then we examined patients after 1 hour and after 1 week, and we did a much closer follow-up. And I saw the IOP spike in 5% of our patients, which is really very little, let's say.
Mm-hmm. Thank you. Another question from Umut Arsan. If there are anterior synechiae, how we can apply SLT?
I put them in between. I've had patients who have a lot of anterior synechiae, and I try to put an SLT in between of the places of the synechiae. If the angle is really completely closed and you cannot even open it when using pilocarpine, I try some laser points, and if there's no reaction whatsoever, I tend to do an iridotomy first. I have done iridotomy and SLT at the same time, but of course you have to have a minimal reaction. You have to see some kind of champagne bubbles, and if your anterior angle is so crowded that you can hardly reach a trabeculum, it's difficult. But that's a very rare problem. I see a lot of people that have some kind of anterior synechiae, and you're still able to put a lot of points in between of the points that are completely obstructed.
Mm-hmm. Thank you. Another question, do you raise your parameters, essentially the energy, in non-pigmented angles? Because it's difficult to have bubbles in these angles.
Yes, yes, I definitely do. And actually, I raise them very high. I raise them above 2 millijoules. I want to see bubbles. I really want to see them, and I want to see them often enough. So I'm actually a little bit surprised that my mean in this study was just 1.4, but because I have the impression that I'm using more than 2 millijoules quite often. But because in pigmented angles, it's always better to start low. So I always start at 0.9 millijoules, but I augment them very rapidly. I want to see bubbles, and I want to see them often enough. And when I see them very often, you can lower the energy again, but it's very little energy on a very big area. So I'm not so prudent with it. I'm enlarging it. Yeah, I use a lot of energy, yeah.
We have 2 questions from Oleg Parkomenko. Which medicine from which group will you replace and which continue to use in case of successful SLT if the patient uses Maximal drops regimen?
What I try to do is to keep the drop that only needs to be applied once. So all of the drops like beta blockers and carboanhydrase inhibitors, most of the time they're applied twice, which makes it harder for the patient to comply. So these are the first to eliminate, and the prostaglandins that have to be used in the evening just once are most of the time the ones that remain, and they remain the longest. If patients are using 2 or 3 drops, I always tell them in advance, we will try to lower the number of drops you are using, because if we can already get you to 1 bottle instead of 2, that will improve your compliance tremendously, and it will diminish the reactions, the ocular surface disease. But in my opinion, in my experience, SLT is always able to replace 1 drop, but not always able to replace 2 drops. So if you're using 2 or 3 drops, SLT will be able to lower you to 1 or 2 drops, but to replace all of the drops is something I don't promise in advance. Mm-hmm. And I keep the drop that you only use once.
And again, the second question is, if the SLT is not effective enough, half or 2/3 of the effect, in 1 or 2 months after, will you repeat the procedure? And if yes, what would be the parameters?
If people really do not react well to SLT, I just wait a little bit. I don't stop any medication until 3 months. So they're still on their medication if I see them back after 2 months. And I don't see the pressure lower. I just keep them on the same kind of drops until their second checkup at 6 months. And if it's still not good, I continue using drops. I will not bother using a second SLT. I will consider them non-responders and not try an SLT again. On the other hand, if everything goes well and their pressure is okay at 3 months and 6 months, but it goes up after at the checkup of 1 year, then I tend to do a redo, because that's somebody who reacted well in the beginning but has a fast weaning of the effect. But the real non-responders, those that do not react after 3 months and 6 months, I don't bother. I don't redo.
Yeah. And then more questions, and then we can finish with those 2 questions. What is the highest IOP level you treat?
Is there a limit? I don't really think so. I can't say that there's a limit, but the highest IOP very often is because of an angle closure or an intermittent angle closure. So you first would have to treat that. And sometimes I do iridotomy and do an SLT at the same time. But open angle glaucoma, in my experience, doesn't really have all that high pressure. And the problem is high intraocular pressure is always picked up very easily by my colleagues in my clinic or by other colleagues. The real problem I find is the normal tension glaucomas. They're not picked up so easily. You have to look at the cup-disc ratio, and it's missed very easily, which is probably the reason why I have so many normal tension glaucomas in my primary group. I don't think the high pressures are the real problems. The problem is the low pressures, because you miss them more easily.
And then we received the same questions several times. How many times can we repeat SLT?
There's no limit. There does not seem to be a limit. SLT has been used now for about 20, 30 years. I haven't seen many studies doing 4, 5, 6 SLTs, but since our study shows that SLT has a tendency to work for 3 to 5 years, you don't have to repeat SLT 5, 6 times. If you repeat it 3 or 4 times, it's more than enough. And since it creates no scarification, you can hardly see where it's been applied. there doesn't seem to be a limit as to how often you should use it.
Mhm.
Anyway, the patients treated are mostly above 70 years, so they don't live for 50, 60 years anyhow.
And we just finished with this one. Can we use SLT in pediatric practice?
Yes, that should be possible. I can't say that I've seen many publications on that, but I think it might even work better because you are looking for an inflammatory reaction. You are looking for the body to heal itself, and that should actually be even easier. The only question I am worried about is whether you would have to do it under general anesthesia, because I don't see a child sitting still and having a lens put in his eye and having 100 points, laser points applied. So I think the problem would just be to get it in, to get it done. But I think it would work just perfectly. I would even expect to have it to have a better effect in children. So yes, I would definitely use it on children too. Yeah.
Yeah. We have several questions, but I think we cannot finish, too late. So it's almost 6 o'clock. But thank you very much for your attention. Thank you very much, Professor De Keyser, for all these interesting results, all this information about SLT. Thank you very much for your attendance to this webinar. We hope in the future to have more webinars also on SLT and other topics. So thank you, everybody, and stay safe. And also, we send you the link soon to watch again this webinar. Thank you very much.
Thank you.
Thank you. Thank you.